So, good morning, good afternoon, good evening, good late night, depending on where you are in the world. Today, we've got a couple of interesting things I'd like to talk about. We get a lot of, both of them are things that are responding to our audience. One is we've gotten tons and tons of interest in this whole question of do you have to carb load before an OGTT? And how do you interpret OGTTs? So, Jesus found an interesting article in that space. It surprised me at first until I read it, and then we got a little bit deeper into it, and you'll see why once we get into the analysis. But then there's another topic that has come up multiple times. There's a lot of people, everybody wants a pill to make themselves live forever. David Sinclair talks about that. The pill, the anti-aging pill. He's discovered, things like the sirtuins, things like, I'm having a senior moment, Jesus. What's the stuff that you find in red grape skins?
I'm blanking on that.
Somebody on the channel will remind me. You continue to make a little bit of progress in that space, but at the end of the day, it's still not where it needs to be. So one of the things people had said based on that was, well, maybe you should just drink red wine because you get it in that. That's another little clue. But the other side to that, the downside is you'd have to drink 100 glasses of red wine a day to get the amount that you need. So
You're talking about resveratrol?
resveratrol,
Oh,
yes. So much for somebody in the audience. You remembered, and I didn't. So bottom line is everybody wants to get a pill. And one of the big options that you hear about a lot is, well, what about some of the pills that we're talking about today? And the anti-aging pills that we're going to talk about today are yet another story. So let's go ahead and why don't you get us started, Jesus, in terms of an introduction?
sure. And I'm going to ask Gilbert and Rafi. I don't know if it's just me. I think we lost the presentation for some reason. But if they can help us with that, just so we can saw it. But just a reminder of thank you so much, guys. So a reminder of the previous topics we discussed last week. We discussed about life purpose and lifespan, which at the beginning might not seem so much of a what does have to do with preventive medicine. But the truth is, we showed a couple of studies that Dr. Brewer has reviewed in the past about how having a life purpose does have an impact on overall health and survival. And we saw how Holocaust patients had a better expectancy of life just because they had a better life purpose and the impact that it has on cardiovascular mortality. So that's something that you want to check out. Well, Dr. Brew also has had Dr. David Wright as a host, and they had a really interesting discussion about ApoB and other inflammation markers and how plaque gets developed. Dr. Wright brought some really interesting slides and a really cool mechanism on how plaque gets built and how you can track that progress with inflammation markers. And we discussed about ultra processed foods and how they impact cognitive decline and just another reason of avoiding these types of foods out there. The courses are on the website. Really interesting stuff. I know we have a really knowledgeable audience, and if you are interested in seeing more about understanding more about inflammation and the root causes of inflammation, heart attack, and stroke, you might want to go ahead and take a look at these courses. I'm pretty sure that once you go through them, you are definitely gonna know more than a lot of doctors out there, at least on this space.
Hey, Suze, let me interrupt just a second. We talked
Sure.
about covering some of the questions earlier. You've just mentioned two things that Rick Folia has already asked about. He asked about David Wright's presentation the other day, a couple of weeks ago, and David mentioning that MPO and PLAC2, LPPLA2, are great fire alarms. So it's talking about David Wright's discussion and cardiovascular inflammation. His question is fairly detailed. It shows that he's been listening to some of our deeper, maybe more arcane bunny holes, but it shows some good understanding of a question and a concept that I think is worthwhile for those that are at that level. And that is, okay, so David talked about MPO and PLAC2 being good fire alarms, but in earlier videos, I've criticized PLAC2 and MPO. Both have significant false positive rates. And so how do we ensure good and accurate results? The bottom line is, there's a concept within medicine that if you have a panel of tests, multiple tests to look at an item, there is no single good test. If there were a single good individual test, you'd use that and you wouldn't use anything else. Well, first of all, very few doctors look at cardiovascular inflammation. What, 1%, maybe less, probably less. And of those that do, almost all of them look at only one thing, HSC C-reactive protein, high sensitivity C-reactive protein. Now, C-reactive protein has a problem. I mean, you look at studies with like Paul Ridker, Gavin Blake, some of those folks at Harvard, and some of the other studies that are looking at cardiovascular inflammation. They're basically saying, okay, we're just going to look at this one item. Well, it's very different if you're just looking at a large population of people and you want to find out, does this one bioindicator have any validity? That's different from looking at one individual and trying to figure out, we've got an N of 1 here. Do they have cardiovascular inflammation or not? So with C-reactive protein, again, it's the most, of the group, it's got the most common biological false positives, meaning a lot of things can happen biologically that cause that test to be positive. It's not specifically a cardiovascular inflammation test. In fact, we've got a lot of patients that have inflammatory diseases like rheumatoid arthritis, psoriatic arthritis, and their rheumatologist is following them with us. And their major risk factor often is that inflammatory disease. They're following them with HSCRP. Now, that would be okay if that were the only time that you see a positive HSCRP, but you see it with things like cuts and bruises even. You see it with, the only time I've had an elevated C-reactive protein is with when I had a sore throat 2 weeks before. We see a lot of elevated CRP with COVID. And as you realize, in terms of thinking about bunny holes in this topic, I haven't even gotten to MPO and LPPLA2 yet. So let's get to that for a second. MPO is the most common laboratory false positive. And what I mean by that is there are a couple of laboratory techniques that cause very common problems with MPO. The two techniques would be, number one, if the venipuncturist takes too long to spin the sample down, or number two, if the pipette goes too deep into the spun sample. What have those got to do with it? Well, MPO exists in the immune cell, myeloperoxidase. So if you get immune cells instead of serum, you can get a false elevation of MPO. So how often does that happen? It happens pretty often. Finally, with LPPLA2, you get problems with genetic variations. Some people just tend to run a little bit hot. The other thing is, you don't see this last item anymore, but some labs tended to use lab kits for LPPLA2 testing, which caused a little bit of elevation. So at the end of the day, you got to ask the question that Rick Foley is asking: what do you do? Do you just not test for it? Do you ignore it? I don't think that's a good solution. Do you just test using HSC reactive protein? Maybe okay for large studies like, Gavin Blake and Paul Ridker are doing, but still not the best for an individual patient. If you're looking at an individual patient and cardiovascular inflammation is a possibility, they've got potential arthritides, or most likely prediabetes, diabetes, then it's better to do the panel, go through the details, and look at the overall. In other words, unfortunately, you got to be able to think, you got to know a little bit about the testing, and that's where we come in and help. So I hope that wasn't too much of a digression, but again, it's a common item, and we wanted to try to hit some of these questions earlier rather than miss them. So thank you for your patience with me, Jesus, as I interrupted.
No, no problem. And I think this is a really common question that we have, especially with other markers and other tests, such as ApoB, for example. If you marry with one of those with this test and you are criticizing just one test, every test is gonna have flaws. There's no one size fits all. And when we do go ahead and make an interpretation of lab results, we compare results from one test and another and how those correlate and get a definitive analysis of everything. So if you go ahead and just focus on one test, there's going to be mistakes. And it's like looking at the elephant on different parts of the body, and somebody who's going to say they're seeing a tail, other people are going to say that they're seeing a foot. But it's not until you put all of that together that you see the whole picture. So, yep, that's important. And if you want to go ahead and see more of these discussions and see more content, join us on Locals as well. And we have some folks that are following the program right now on Rumble, and we appreciate that. The book Dr. Brewer he wrote a book a few years back. It's not that new now, but the knowledge and the things that you can see there are really, really important. And just having this book might keep you away from the cath lab and having a stent that maybe you don't need. And just go ahead, take a look at it. It's really interesting. It has a lot of information on how to identify if you really have a cardiovascular inflammation and plaque problem. We are already accepting Medicare, straight Medicare. We have done a really terrific job on that side. Dr. Miranda, Michelle, James, all the team, Fred, Craig, I don't want to forget anyone. They're all doing an extraordinary effort to help Dr. Brewer. And Dr. Brewer is doing an effort as well on expanding a little bit his schedule to see more patients. And we're right now up and rolling, and we're just waiting to get more and more patients that are on a waiting list to see Dr. Brewer and get that access to care by Medicare. So that's something that it's on. And if you have straight Medicare, just go ahead, fill out the survey on our website, give us a call, send us an email. All of that helps to get you on the waiting list. I'm not going to stop too much on the network, the PrevMed network, physicians network. We have a lot of patients that ask for, hey, do you know somebody who thinks like Dr. Brewer and that I can see on my own town? We are working on that. It's going to take a couple of months, but we already have some interactions and communications from physicians who are interested in this program. So if your physician you think is going to be interested in knowing and learning more about prevention, giving us a call. For full scripts, we understand that um, having supplements, it's rough on the side that they're not as regulated as medications are. So we are using the services from FullScript to get access to more reliable supplements. If you want to go ahead and take a look at those, you're going to find a lot of options that might fit your needs. And we're going to move to the um, short content for today. So somebody in the audience, I'm blanking on the name of this person, sent an email and said, hey, have you heard about the adaptive glucose model? And they were saying that it is similar to what we discussed with lean mass hyperresponders, meaning that when lean mass hyperresponders go into a low carb diet, their LDL levels go up. And this person was saying, hey, I think adaptive glucose, it's kind of similar, because there's people who say that if you go on a low carb diet and then you get an OGTT, your blood glucose levels are gonna go through the roof, and you're gonna have a false diagnosis of diabetes. The truth is, we have covered this in the past, and we haven't found reliable evidence that says that that's the case. But I went ahead and take a closer look and look for other stuff. And this is what I found. So this is an article from the Journal of Endocrine Society 2021. Uh, one thing is for sure, the evidence on this space is limited and it's not as strong as we would like it to be. But this is a case report and an expert's opinion, which are the lowest levels of evidence that you can publish in a scientific article. And they say, as a background, that the acceptance of A1C for diagnosis of diabetes has reduced the amount of OGTTs that are being performed. And we have discussed this in the past, and we mentioned how when you have a pregnant patient, it is mandatory to go ahead and get an OGTT to identify if there is some pregnancy related diabetes. But we're not doing that for the rest of the population. And we have mentioned this in the past. Even the AAC, the American Academy of Clinical Endocrinologists, have said that A1C is not good for diabetes diagnosis alone. So the assumption here is that there is a false positive risk of diabetes when having an OGTT in somebody who is setting on a low carb diet. And they mention a case report from a 20-year-old healthy woman, a volunteer for this study, whose BMI is 20.7, so it's a lean person with no history of diabetes and that is physically active. So if you see here, and you go ahead on the table, on the table one, you will see that they're saying, okay, we made a fasting blood glucose screening for this patient, which resulted in 71. We did an OGTT with a low carb dinner prior to the OGTT. This is what they're discussing. If somebody is having a low carb diet before the test is going to have the risk of diabetes or having a pattern of diabetes. Uh, this person they tested, she had 60 glucose of 60 on fasting, 153 at the 1 hour, 200 at 2 hours, which meets the definition of diabetes, and a 152 at 3 hours. Now, they said this is a low carb dinner, but if you go deeper into the article, and this is where Dr. Brewer and I, when we first saw this, we said, okay, they might seem to have something until we read this part. So the diet of this person, this volunteer, was a high carbohydrate breakfast with French fries for lunch, eggs, bacon, avocado on toast for dinner, and 8 ounces of orange juice. So our main question here was how low carb diet this is. I'm not sure that this really has less than 100 carbs on one day. So the assumption that she had a low carb diet prior to the study, right here, I think we're missing that. They said they showed. Go ahead, Doc. Go ahead.
Pardon the interruption, but when I originally saw that, I thought that's what they were referring to as the carb challenge.
No. This is they do the standard 75 grams
Yeah.
study the day. Yeah, this was prior the day before. So if they're saying the low carb diet causes false diabetes, at least on this time they didn't really test for that. And they say that they send this to experts on type 1 diabetes. So and this is something that you might agree or not with me, Doc, but if you said you go to an expert that all day is seeing type 1 diabetes, they're gonna think this is type 1 diabetes, and they suggested testing for type 1 diabetes on a 20-year-old woman. I know that might happen, but I don't think that happens really that often.
It brings up the point of the difference between type 1 diabetes and type 2. They're both called diabetes. The reason for it is they were originally named by urine in the or sugar in the urine, but they're two totally different diseases. One is an inability to make insulin. That's type 1 diabetes. The other, and so that's a problem with the pancreas. The other is an inability to respond to diabetes by the insulin, or to respond to insulin by the insulin receptors, which is in a totally different anatomical place. That's out in the muscle cells and the liver cells.
Definitely. So, and you usually see type 1 diabetes more on children. There is a genetic predisposition to not produce insulin, and they do require to be injecting insulin. Type 2 diabetes it's has the other mechanism that Dr. Ray just described. So they said, okay, let's compare these results to a high carbohydrate diet, right? And they asked the volunteer to eat at least 150 carbs for 3 days prior to the testing, and she ate more than 50. But the thing is, they didn't measure the same way they did the first time. They just measured fasting and 2 hours. So remember the article from John Ioannidis? I'm definitely
Mm-hmm.
pronouncing the last name wrong, but and this just got, yeah, Ioannidis, and that just came to my mind.
Yeah.
How much is this them not measuring that or not reporting the 1 hour?
Yeah, if I could, real quick, Johnny Ioannidis is that's a Greek last name. He's faculty at Stanford. He's got one of the articles that he wrote broke records in terms of being the most read article in, what was it, the public?
Public Library of Science.
Plus Public Library of Science. And the article was all about how quite often, very often, stuff that gets published is wrong. And the reason for it, has to do with a lot of things. But one of the most common reasons is that it doesn't make sense. It goes against what we think we know already. And therefore, it's, quote, newsworthy, end quote. Well, the problem with that is that you get folks that have a very different filter. That's not bad, but you also get folks that do a bad job in terms of their science. And this is clearly, as Jesus has pointed out, already a couple of really bad job components. The first is they didn't, several quick things. They looked, the way they measured they did the OGTT was totally different in the first version versus the second. The, quote, low carb diet was not at all low carb. It was very high carb. And again, so it's easy to mistake what they're doing in terms of the risk factor. So if you see the high carb and low carb as a risk factor for a positive, false positive diabetes test, neither the high carb diet was done appropriately, nor the control. It was not done appropriately. And the testing components were not done appropriately. So it's major challenges. And you go back to Jesus's point and you have to ask, as John Renitas would ask, why in the heck did this get published?
Yeah. And I can tell you from my residence standard, when I was a resident and the specialty, I published a couple of studies, and you will see journals that are really critical, and they will let you know, we will publish this when you solve this. And there are other journals where will say, okay, this is good, let's publish it. So
Right.
the peer review still has its flaws, and peer review, just so everybody knows, people who do peer reviewing, that's all voluntary. Nobody gets paid for that.
And another component of peer review is, who are your peers, and are they jealous of your work, or are they busy trying to get their own stuff published? Are they going to agree to just publish anything that you put out because they're a big fan of yours, or for some other reason? And again, as you get deeper and deeper into the guts of how this is made, it reminds you of how science is made. It reminds you of the old quote that's attributed to Mark Twain. People that like law and sausage shouldn't watch either one being made. People that like science shouldn't watch it being made.
I'm a witness of both.
Yes, me too.
Yeah, I just shared that I had a chance to go into a factory where they produce sausages, and I just stopped eating that for a couple of months until I forgot.
I actually spent time in a hog rendering plant one time too. Spent a whole day, and it was fascinating. There were, well, different subject for a different time. Interesting bunny hole, though.
Yeah. And the other thing here, they didn't do an insulin survey. And an insulin survey definitely is going to be really interesting to compare what really is happening with that insulin. If it's just producing too much insulin, or there's really not enough insulin that supports the idea that that's the issue. So it's an incomplete study. And we will going to cover more about adaptive glucose mechanisms on the long form content next week, if you're interested for you to join us next week. Okay, so that is for the short content for today.
So if you'll give us the water ball, So as we started off, I started off with a couple of significant distractions, a couple of senior moments. Couldn't remember resveratrol, and I couldn't remember rapamycin. We get a lot of questions about rapamycin, and hey, doc, why don't we just use that? It's the pill. It's maybe what David Sinclair wished he had invented and found, but didn't. I still think it's too early for prime time. Why do I think that? Why don't you go ahead and get us started on it, Jesus?
Yeah, and just started with the conclusion. And just
maybe I shouldn't have. Maybe I gave away the score too soon.
That's fine. We have two methods. We can say, okay, we're gonna show you why, and unlock a lot of YouTube videos that stay like for 5 minutes, just they're creating suspense for you to stay at the end of the video. Or we can just go ahead, okay, Rapamycin is ready for prime time, but I'm going to tell you why, right? So what happens here is rapamycin, or sirolimus, or Rapamune, and there's an analog, kind of newer analog called RAD00.
Uh-oh, you went.
I really don't know who. Oh, okay, I'm back.
Yeah, you're back.
You.
Let me just interrupt for a second, since I already have.
Sure.
Another pronunciation is sirolimus for that second one, or Rapamune, and everolimus, or RAD001. All FDA approved for mTOR inhibitors. And one of the conversations we were having before we started the show is, why in the heck would FDA approve those? Just a quick bunny hole on it. The major approvals that I'm aware of are for drug-eluting stents, which most of you know our opinions of stents and chemotherapy. So maybe a little bit different bar to achieve to get a FDA approval for those items than for just giving it to people who have no other known quote disease end quote than old age and want to prolong their life. So let me
Yeah,
hand it back to you, Jesus.
and I think today I have my conspiracy hat on because the other thing that I'm thinking is how much of that has to do with money.
Yeah, it's a
I,
really good question.
I don't know. I don't know. I'm gonna stop right there. I don't want to have somebody just knocking at my door later
I've
on.
always tried up until the past few years to avoid politics. I got too deep into reading too many politics over the past 2 years, and I think I'm not the only one. I've always said, I'm not a conspiracy theorist, but I can't help but go there some too.
Yeah. So, and by that we're not saying that rapamycin might not help. That's for sure. And also, I don't know who comes up with these names. Really, it's incredible how complicated can this be sometimes. So it has shown rapamycin has shown to extend lifespan in mice, dogs, and some primates. And we were
Let
just
me
discussing that.
interrupt one more time.
Sure,
I
sure, sure. Go
appreciate your
ahead.
patience today, but you mentioned
No.
the thing about uh, where did they come up with the name? Uh, this came from Easter Island. Um, I don't know, Raffi, if you can find a picture of Easter Island. It's the island that has these giant heads on it, made out of stone. And it was discovered in a similar fashion to the way a lot of drugs have been discovered in the Amazon, different environmental areas where you might find interesting stuff. They found this thing and they called it rapamycin, and they used it for antibiotic and a couple of other things, as we've mentioned already. Rapa Nui was the name that the local culture used for that island. So rapamycin came from Rapa Nui.
But everolimus didn't come from the island of Everolimus or something like that, right?
Or Sirolimus from Sirui or whatever. So yeah, I get you. It's the rest of them I have no clue.
Yeah, that's gonna be an interesting topic to just make a quick Google search and see.
Yeah.
So back to the point. So rapamycin has shown some benefits, and we just were looking at some studies. There are some studies made on people, on human subjects, but those are usually small studies, no more than 24 subjects for specific purposes, such as other autoimmune disease, cancer, and transplants. Now, what happens here? Rapamycin main mechanism of action is inhibiting mTOR, which is one of those drivers that regulate both growth and aging, also regulate glucose and lipid metabolism. So when you talk about glucose, fatty acids, insulin, growth factors, and oxygen, all of those activate mTOR and gets you to an oxidation cascade, which is just like the rust that you see on your car. It's just happening ever so slowly on the body, and that's basically the mechanism of aging. And mTOR drives that for a lot of organs, and it's all over the place. So the theory was, well, let's decrease the activity of mTOR, and that's gonna promote that aging and oxidation doesn't go to faster speed, and we can go ahead and decrease aging. That was the theory, and that was something that they want to test.
Pardon me, but let's go back for a
Sure.
second and talk about a couple of things. One is the mechanism and the association with insulin, but we'll get to that and IGF in just a second, insulin like growth factor. But first of all, another comment about names. Are you familiar with how mTOR got its name?
No, that's gonna be interesting to listen.
It's an acronym that stands for mammalian target of rapamycin. So again, you get into some circularity here. A lot, almost the majority of the science around what we're talking about with rapamycin and mTOR and some of these things. I did a series on it. There was a fella, I'm blanking on his name, but I did a series on him. He was at MIT and Harvard. He did a lot of work and got a lot of awards on his work in this area. But as you can see, a lot of it just started from somebody picking up some dust samples on Easter Island, coming back and starting to look at what actually happens when you use that chemical in a biological medical area, and then starting to see some impact, and then starting to say, wait a minute, there's something else going on here. To that point, it's very much related to the mechanism that you're describing. Growth and aging are actually very related, and they're both related to there's another chemical very similar to insulin, and it's called IGF. That stands for insulin-like growth factor. And so rapamycin, sirolimus, rapamune, these related chemicals are actually looking at stopping the activities associated or driven by insulin and IGF. One final comment, and then I'll hand it back to you. A lot of people have in this space have looked at men's health and said, you know what? There may be a role even for metformin in terms of prostatitis. Now, you think about that and you think, where would that come from? Or prostatic cancer. And are you familiar with that linkage?
I have heard of that, but I haven't read about it. And it has to do with some of this mechanism, because we have mentioned the
Correct.
same study about metformin and aging.
Correct. And it has to do with metformin slowing down some of the glucose-related activities and glucose stimulating, hyperglycemia stimulating insulin and insulin-like growth factor, and that insulin-like growth factor stimulating the growth of uncontrolled growth of prostate cells. So again, just there's unending bunny holes you can go down when you start looking at the science around this. I'll hand it back to you.
Sure, and as you might see, this brings me back to what lectures in medicine are. Whenever you have a trainee introducing stuff and you have the expert on the other side, that's when the conversation gets more productive and you get more knowledge out of it, and everybody learns. So that's really good. So what they saw also, the evidence has shown, is that rapamycin has similar effects on the body from what prolonged fasting can do as well. So prolonged fasting inhibits glucose utilization by non-brain organs, because the brain is more dependent on glucose than other organs. So other organs do have a chance to use other resources to produce energy. And when you are on prolonged fasting, you are depleting some of those reserves from glucose, and you get the body to create glucose out of other products such as fats and even proteins. So when you are on prolonged fasting, you're going to have low levels of insulin, gluconeogenesis, which is basically that, creating glucose out of other sources, lipolysis, which is basically breaking fat molecules to create energy, and ketosis. And what some people have seen is that when you are after you are depleting on glucose because of fasting, and you retake glucose, some of that glucose might not be able to be processed correctly, and that's going to lead to some glucose in the urine. And they mentioned that even prolonged fasting, considering this, there's a theory that prolonged fasting may increase your blood glucose levels once you retake glucose intake. But that's only if you are taking high amounts of carbohydrates, just because your body has to be retrained to metabolize carbs the way it used to. And similar effects can be seen with rapamycin, and even effects like this, but in a greater scale. So prolonged fasting on rapamycin might have similar effects. That's the whole point of this slide.
The and part of that point is in that third bullet. That gets back to part of the thought processes that are driving this concept about false glucose tolerance testing. People think, there is probably something associated with this mechanism that might be driving a false positive OGTT. And I will add, if you're confused on this, on some of these items where they seem to be the opposite of what they are, you're not alone. Don't feel like you're alone, and don't feel like, some of it's the way we present it, but that's not the whole thing. There's some challenging concepts here. And again, pardon me if I'm taking away the suspense, but because of some of the confusion of this, the logic behind the science in these areas, I'm just going to step up to 30,000 feet and say it again. The topics that we're talking about today, I think, are not quite ready for prime time. Not so much the topic, but the assumption that you can take chemicals that that are going to impact this mechanism and artificially, through medication, increase your lifespan. There are too many things that we don't understand about these mechanisms and the medication, using medications to drive it. And then you look at stuff that's really clear, really simple, really safe, like managing lifestyle. Why don't you just manage your lifestyle?
Yeah, and this one is basically that point of, if by prolonged fasting you're not eating carbs, and then when you reintroduce carbs into your body, you're not gonna know how to handle that, and that's gonna cause high levels of blood glucose. There mentioned that maybe rapamycin is causing that. The same
Mm-hmm.
mechanism. The difference is that you might be still eating some carbs, and that's gonna lead to your body not knowing what to do and increasing your blood glucose levels, because there's a blockage on how to metabolize carbs.
And one other comment about that before we go to the next slide, as we will see in the long form content yesterday, Jesus mentioned that we'll be covering more on this carb loading question. As you'll see, the best information, the actual randomized clinical trials, does not indicate that this is actually happening.
Exactly right.
It's all theory and a
Yep.
couple of really bad case reports.
So see what happens with mTOR. mTOR stimulates beta cells growth on the pancreas. Beta cells are the ones that are in charge of producing insulin, and it leads to hyperfunction and ladder exhaustion, which is basically the road that you get with type 2 diabetes. You get an overproduction of insulin, and at some moment you get insulin resistance, and the pancreas just stops producing that. That's when you get to your physician and they say, okay, your pancreas is not producing enough insulin, let's inject that on your belly. That's the ladder stage. And this process is similar in other organs, such as kidneys. And this process, at least on theory, and with some studies that had been done, can be suppressed by rapamycin everolimus. And some studies showing insulin resistance or glucose intolerance after chronic use of rapamycin, mostly related to the activation of mTOR, what we were just discussing. If you are telling your body not to metabolize glucose, glucose is going to stay on the bloodstream and might even get lost on the urine. And the theory is that you might have high levels of glucose on the blood. And how dangerous is that? How many damage that's been done because of that? That's unknown right now, at least for the mechanism of rapamycin. Um, in transplant patients, they have seen that it might be high levels of glucose, but not necessarily higher risk of diabetes. And in healthy humans, quotes, including elderly, hyperglycemia, high levels of blood glucose in the blood, has not been noticed so far.
So
Small
as we
studies,
men-
definitely.
yeah, so as we mentioned in the last slide, there's a logical case for it that a lot of people are pushing. I'm not 100% behind the logical case, and when you actually look at the last two bullets on this slide, the evidence is not leaning too far that way either.
Yep. Just before, we're almost at the end of the conclusion of this study. So, other studies suggested that up to 50% of patients undergoing prolonged fasting achieved non diabetic fasting plasma glucose levels by week 8 of a very low calorie diet. So, this is the lifestyle component that we're mentioning. And this motivated patients to think that they are able to, quote, reverse, end quote, type 2 diabetes, just like Jason Fung says, that you can cure
Hmm.
diabetes, right? But it's part of the reversal of controlling diabetes. And the other states that rapamycin has a stronger inhibition of mTOR than fasting, especially in old age. So, uh, I think in theory it might be the case, but there are a lot of factors involved to see that efficacy. So, in summary, there's evidence that rapamycin has a potential to prolong life and improve health overall. Some scientists believe it might cause diabetes. When combined with tacrolimus, which is something that it can be used for some types of cancer and for transplants, it might cause diabetes in renal transplantation more because of the tacrolimus rather than the rapamycin. As an anti-aging drug, it is not expected to cause hyperglycemia. It can be combined with metformin if hyperglycemia is still a concern. And intermittent rapamycin use might have the similar effects and has been studied as well. And just like Dr. Bruce said, I think the science is not yet there.
There's certainly a lot of logic. Sometimes the logic is backed up, sometimes it's not. And again, if you go back to the last slide, at least the first couple of points here go back to the basics of what I'm talking about: lifestyle management. If you fasting, different versions of fasting, decreasing your caloric intake, those are, you can't outrun a diet. You can't out supplement a diet, and you can't out medicate a diet. And you can't out rapamycin a diet either. You just can't do it. So manage your lifestyle. And most importantly, the king of lifestyle is diet. Manage that. We know what that does. There's absolute uh, evidence about how that can manage our lifestyle and prolong life. And as many folks would say, yes, a whole bunch of this has to do with managing diabetes. Why? Because diabetes is just incredibly underdiagnosed and incredibly destructive. We went through incredible changes with our society because of a very destructive virus that came through the past few years. There was only 2 or 3 weeks when that virus was credited with killing more people than heart attack, stroke, cardiovascular disease. Even during those 2 or 3 weeks, more people within that virus category were dying with comorbidities of diabetes and cardiovascular disease. So the bottom line is it's diabetes and cardiovascular disease. It's simple. It's just not easy to deal with it.
And if I may go back to that point, I think COVID just accelerated cardiovascular deaths. It just made them happen early than they were supposed to happen. And going back to this point and assuming that they are right, that rapamycin can increase glucose intolerance, the point that still stands. If you're thinking that just by taking rapamycin and then staying on your high carb diet, you're gonna fix things, you're probably going to do the opposite
Right.
because you're gonna untrain your body to metabolize those carbs, and you're gonna have still high levels of blood glucose. So lifestyle is king.
There you go. So that, I think we've beat up rapamycin and some of the research around it, supporting or not supporting it. Enough for right now. Let's go into the Q&A. Again, thanks, Jesus, for covering a very murky topic, a topic that I'd gotten a lot of encouragement and push and requests to go into, and just didn't have the bravery to go there. But you did, and I think it was very enlightening and a lot of fun.
Thank you.
We said we were going to start with super chats. Clean Slate gave a super chat. Thank you so much, Clean Slate. You know, these super chats, Rafi is showing you up in the top right-hand corner how to do that. You go down to the bottom of the chat, you can see a super chat button. What's the purpose? To contribute to getting this kind of life-saving information out to the rest of the world. And it is the rest of the world. We used to broadcast an hour later, but we had so much request from a certain area in Asia to move it up an hour so they could attend live that we did it. So that's why we're broadcasting when we are. Clean Slate, $10. Thank you for the MPO LPPLA discussion. Putting a request for a complete series of these tests in front of a lipidologist, including OGTT, expecting pushback, 1800 plus calcium score, but do have some improvement in 1 year CIMT. Well, congratulations. Good luck on putting this in front of a lipidologist. I hear the term lipidologist and what you're getting ready to do, and I can't help. I see Jesus over there laughing too. It's if there's one profession I'd hate to be, it would be a lipidologist, because at the end of the day, you've spent extra years of your life training in lipids. And the reality is, yeah, lipids cause some challenges, but they're not the underlying driver. It's sort of like getting a doctorate in firefighting, but what you really studied was innocent bystanders and gawkers. You know, the lipids tend to be bioindicators more than anything else. If you'd like, we can certainly help if you run into problems with your lipidologist. That's what we do. As Jesus said, we've been doing this not only all over the U.S., but all over the world. Singapore, Thailand, the Middle East, Western Europe, South America, Australia, you name it. We've got patients there. And to help make it a lot more accessible for folks in the U.S., we're doing Medicare as well. Good luck on getting those tests done. I'm curious to see what you mean by some improvement in CIMT. Any other comments, Jesus?
I think we who are in preventive medicine, nutritionists, and especially lipidologists, you have to know something about carb metabolism, at least to understand a little bit of its influence. And if you are over 200 pounds and telling people that their LDL is through the roof and they need a stent, we have a problem.
Oh, yeah. Don't get me started on that. I'm not going to.
Let's leave it at that.
We'll leave it at that. D-Dutton, rosuvastatin, pitavastatin is the major underlying method by which they reduce inflammation through reduction of oxidative stress. Or I think you're asking, I think by question mark, you're asking, is that the major? And I would say no, lifestyle is the major thing. I mean, it's funny, we'll go through some of the arcane details of, maybe not arcane, but details of labs, like what your fractionation on your lipids are telling you. And patients will say, that's very good. So I want to increase my large HDL. So how do I do that? And it's like, well, yes, I mean, the statins may help, but it's lifestyle, and decreasing your carbs, decreasing your body fat, increasing your muscle mass. All of those things are what decrease oxidation and oxidative stress.
Uh,
Other comments from your side?
yeah, and of course that doesn't mean that statins don't have a role. They do play a role when you already have some plaque, and they do decrease cardiovascular inflammation. And the mechanisms are not well understood, but it's thought that it had to do with something that's called GTPA, GTP acids that are kind of proteins that have a mechanism, and they are involved on signaling and communication between cells, and they decrease the effect of some inflammation components. There are a lot of names for that, but basically they are decreasing inflammation through those mechanisms and something that is called the pleiotropic effects. So statins do play a role. Uh, but if you really want to take care of this, of course, they're just an add-on to the lifestyle component of the treatment.
Well, to that point, he goes a little bit deeper, or he or she goes a little bit deeper in terms of saying, okay, what about the impact on like VLDLs or remnant cholesterol? You want to go first? Do you want me to?
I, I will just say that, of course, there is an impact, but that's not the main point. I think if you're taking statins just to decrease ApoB or decrease triglycerides, we are looking at a consequence of the real effect, which is decreasing inflammation. Because that's what the people who use Lipitor do. Like they say, okay, 20 milligrams were not enough to decrease your LDL. Let's push that to 40. And that's not the point.
Very, very good point. So, as you point out, that yes, those are important roles, but you can get that with Lipitor. The thing that you don't get with Lipitor, and the reason we don't recommend it, the reason we used to use a lot of simvastatin, pravastatin. Those were good meds, but you had to watch for KIF6, which again is a genetic bunny hole that we don't even need to go down anymore. Any of the statins will do what you're talking about, D. Dutton, in terms of decreasing ApoB and decreasing the remnant cholesterol. What we're focused on a little bit more, or a lot more, is the pleiotropic mechanism of decreasing cardiovascular inflammation.
And to the point of the platelets, my understanding is that statins actually decrease activation of platelets instead of hypersensitize them. But the impact is not that important either, like to worry about clots or bleeding because of statins.
So good morning from Elizabeth Pan in sunny Virginia. Good morning from Rick Folia from Georgia. And we talked about Rick's question about cardiovascular inflammation. So we get a lot of interest in cardiovascular inflammation today. 10Man63 was helping me out with my senior moment, my distraction. Thank you so much. Yes, it's resveratrol, a little bit different spelling, but Daniel Harrell is as well. Good morning, Dr. Vegas and Brewer. Smash that like button. Thank you so much, Rebecca. We appreciate it.
I have a friend that's called Dr. Vargas, and that's okay. I mean, that's okay. I'm Dr. Vega, but that's okay. I understand. It's like me with Rapamycin and everolimus.
Well, and my first name is actually Fordham. That's my middle name. That's the name I went over. Fordham, like the university in New York. But you can imagine why I just shortened it to Ford. Nobody got it, except my family. Thanks so much for the likes, and thanks for telling us where you're from. Dynamic Duo, Decisivity, thank you so much. Okay, Dave, the retired cop. I'm 1 month younger than you. I think he's talking about me, don't you think?
Definitely. I'm nowhere near to retire.
There you go. I fully retired 2 months ago after 40 years of investigating crimes against children. Last week's program challenged me. I'm exhausted and worn out. What? I'm already having another senior moment. What did we present last week?
Life purpose. And this brings a good point. And I mean that job is challenging. Just taking
Yeah,
care of children, it's
yeah,
challenging. And I think we didn't mention this in the last show, but this is a good moment to do that. Life purpose doesn't have to be static. It can
no.
change. So if your life purpose was something before you retire, and that's no longer something that you're gonna do, you can go ahead and try something different.
As somebody mentioned on the show, I'm very fortunate in that I get closer and closer and closer into what I really, really, really want to do. And I can't imagine being much closer to that than what I'm doing right now. 30 years ago, it was, just being a doc and trying to push prevention more than regular medicine. I'm doing a version of that now, but a much, much deeper version. Um, we talked about other people who retire and end up, their big purpose becomes expression through gardening. It just takes all kinds, but you got to remember purpose is important. This is a great question. I think you mentioned straight Medicare, and I think you got that term from me. I got that term from other people in the fee for value world. And basically, what that means when you hear the term straight Medicare, it's basically talking about traditional Medicare or, quote, fee for service Medicare. Now, if the term fee for service and fee for value confuse you and you have more interest in it, we've got a whole YouTube channel on it. It's a small channel with 20 or 30 videos, but it goes into this whole topic and it gets into detail on what we're doing in the Medicare program. Basically, what it's doing is talking about prevention, fee for value. In other words, we've known forever that fee for service was a really bad way to pay doctors. Doctors are just like everybody else. They they do more of what they get paid for. Well, the simplest way to do medical insurance was to pay doctors for, quote, real work, which meant, well, a prescription. Nobody else can write prescriptions, so pay doctors for writing prescriptions. Well, do you wonder why we have polypharmacy today? Way too many prescriptions. 20% of people in hospitals dying from what the doctors did to them, not what they came in with. And, big problems like that. Well, that tends to be driven by this simplicity of concept of insurance, of paying doctors for what nobody else can do. They do too much of it. And at the end of the day, that's not what we want. If we want to improve health, we need to teach doctors to go back, understand what patients' risks are, understand how to teach patients what those risks are, and understand how to teach patients what really helps. And lifestyle is what helps, as we've said, multiple times, even during today's show. Much more so than medications or stents or bypasses. So the term straight Medicare, old fee-for-service style Medicare. Medicare Advantage is fee-for-value. So thank you for bringing that up. And again, if you'd like your doc to get involved with us, get involved with doing more prevention style medicine, refer your doc or your NP to that channel. If you have questions about it, give us a call at 859. Hey, that was quick, Rafi. Did you see how quickly he did that?
He's reading your mind today.
He is very impressive. Give us a call at 859-721-1414, and we can help you help your doc, your nurse practitioner, get into much more of a preventive style of medicine. Elizabeth Pan, Medicare A and B, and Medicare C is Medicare Advantage or fee for value.
Or
You get a lot of,
disadvantage, how they say.
yeah, somebody likes to say disadvantage. I was just getting ready to say
I'm sorry, I stole your thunder.
anything and everything is going to get criticized. And yes, there are multiple problems with Medicare Advantage, and it becomes disadvantage. And one of the places where I've seen abuse on the provider's side is, much more in the organized area where people would cherry pick the groups that they provide care for, skipping over lower income groups. And the reality is it's more difficult in lower income groups because there are challenges in terms of their ability to, if you're struggling to pay your rent, it's hard to take the time to learn what you need to learn to manage your diet and other lifestyle issues. But the bottom line is fee for value it's the way of the future. It's saving government money, it's saving tax money, and the way it's doing it is the important part. It's keeping people healthier. So, how about you, Jesus? Have you seen any questions that we need to be talking about, need to be
Yeah,
responding to?
yeah, we can go to the next one right here. Rick Foley, I'm planning to do the low carb versus high carb craft test next month. We'll keep you posted. That's going to be interesting to see. Remember to get OGTT and insulin survey because
Now,
sometimes people confuse those.
so and to your point, the only difference between a OGTT and an insulin survey is that you're getting insulin during those blood draws. The labs often screw that up, just like they screw, you know, things
Yeah,
happen.
yeah. They
We have,
sometimes measure one blood sample 3 times, and they
that's
think
right,
that's the way to go.
right. Make sure that if you're going to get insulin values, that they get one insulin with each of the blood draws, not three insulins with one of the blood draws, which is unfortunately one of the things that they're doing quite often and systematically. The question that I have is low carb versus high carb. Is he talking about
Carb
using?
loading or not carb loading? Yeah.
I thought that's what you would think, and I thought the other. I thought he was talking about a 75-gram carb challenge as opposed to a 100-gram carb challenge.
Mm,
The typical OGTT is a 75-gram carb uh, uh, glucola challenge, and the craft format is 100 grams glucola carb challenge.
But
So
is there any difference? I haven't seen any significant difference. I somebody will say that the craft is slightly better, but
well, I think there are a couple of reasons craft is better. The first one is that it's looking at 3 and 4 hours, which gives us more information. The second one, the biggest reason why craft is better, is that it's looking at how much insulin is required to manage that glucose level in the blood. That is the big advantage to a craft insulin survey, and that's why it's called insulin survey as opposed to just an OGTT. First name, last name, laugh out loud. Orange juice is no way low carb. Yep. That's what we thought. And, the avocado on avocado toast is low carb, but usually the toast is not low carb either.
that's why I make a slight emphasis on toast because avocado okay, toast.
When do you use OGTT and when is craft better? Craft is always going to be better. And I can tell you from having used both of those a lot, you're going to miss about 20% of people that have very significant insulin resistance if you don't look at the insulin values. We just had one this week where their peak glucose at 1 hour went up to about 140. It's not perfect, but for a 60-something-year-old, it wasn't bad at all. But then you go back and you look at the insulin, and it was like 150. And it's like, whoa, clearly significant in requiring too much insulin to manage their glucose levels. You'll hear from people like, there's a lot of crossover now between our show and Peter Attia's. And Peter Attia said multiple times, as well as other folks, that hyperinsulinemia alone without hyperglycemia is still causes plaque. And I get that. I think it's true. However, I think what it's missing is that most of the time it's missing times when there is hyperglycemia, where they're not picking it up. Bottom line is it's insulin resistance. And so the other question is, when do you use one versus the other? When you can't use an OGTT when you can't get an insulin survey. That's the bottom line. So, for example, in our Medicare programs, a lot of times Medicare will pay for the OGTT, but not the insulin survey. It's another $50 to $100 to add the insulin levels with it. A lot of times people in direct pay will say, yeah, I just want to go with, I can't go the full insulin survey. At that time, you accept it. The third time is when people say, I just don't want to take 3 or 4 hours. I just want to do the 2 hours and get out. But anytime you can, craft is better.
Leo, Acapulco, do you recommend any CGM? Are they all the same? You have a couple of videos comparing Dexcom 6 versus Freestyle Libre.
I do. And it totally surprised me. On me, the Libre actually did better. Well, on everybody else that's used both, the Dexcom did better. And the Dexcom is a lot more expensive. It's got some advantages in that you can calibrate it, whereas you can't really calibrate a Libre. I think overall, that analysis is true, even though you didn't see that with me. I compared the Libre to a Dexcom and did finger sticks to compare the two. The Libre made more sense, and it actually calibrated better with the finger sticks. Again, I think that just happened to be an anomaly with my single person case report. Now, there's a bunch of them that have come out now, and I keep thinking what we ought to do is go ahead, bite the bullet, and get about 2 or 3, 4 others, and walk around with all of those on for a couple of weeks and see what that tells us. One thing that I am very excited about is 2-3 years ago, nobody was doing this. We were talking about it. There were a few people doing it. You would see a few YouTube videos, but now you've got, what is it? Noom's not one of them, but there are maybe they are. There are 3 or 4 companies that are offering their own CGM. So the bottom line is there is a groundswell of recognition of the importance of watching this. And I had a patient say this actually, I think it was the 30-year-old patient that we saw this week, who also had not very bad OGTT at all, but his insulin values, again, went way over 100, 150. And he said, dang, it's like going through life without one of these is like, without a CGM, is like driving a car on the highway without a speedometer.
And with an FH issue as well, where it just adds another extra layer of complexity to the issue.
It really did. Very, very interesting case. So, Rick Foley, I eat a lot of B12-rich foods, keto carnivore, but my B12 labs keep coming back low. Does that imply I'm a poor methylator? If so, is supplement the answer? If so, what kind of B12 is preferred? You want to take that?
Not sure. It's the metabolism.
You want to think while I respond?
Yeah, go ahead.
And then you can correct me. So no, I don't think it does. If you go back and you look, I did a video a couple of years ago on some recent science review, and it was in a good journal, the New England Journal of Medicine, and it talked about this, and it made one of the points that B12 testing alone is not effective. It can be impacted by a lot of things. So that's why we look at another, and now I just had a senior moment. That's why we look at another test. And what is that other test that we get?
Homocysteine.
Well, homocysteine is a bioindicator, but you go ahead and talk for a second and let me look that test up, because we get it all the time.
I'm thinking of folates.
No.
Well, what I was going to say is not only because B12 is not that reliable on the lab, low levels of B12 are not usually the only thing that you should look at for. And I think Dr. Brewer just got the answer he was looking for.
How could you tell?
Go ahead.
Methylmalonic acid, you know that. We cover
Yeah.
this all the time. So here's a couple of things. Let me just use this as an opportunity to do a refresher on B12 and methylmalonic acid, B12 testing, why we would even do it. And Jesus, you know what we ought to do? Maybe go back and redo some of that content out of that video on that New England Journal article, because what I'm doing is a years later summary off the cuff. Why don't we get the real information and provide it again? Because it's very helpful. One of the the common problems that we see, as Rick mentioned, you can get it with certain types of diets. He thought he was protecting against it with a B12 rich diet, keto carnivore, but his B12 labs kept coming back low. Does that mean that Rick needs to be concerned? Does that mean he needs to, that he's a poor methylator? Well, remind me to go back to methylation, because that's a totally different bunny hole. It doesn't mean that he's a poor methylator, and it really doesn't even mean that he has low B12. It means that his B12 test is coming back low. We get a test called methylmalonic acid, and again, I covered that in the past, and we'll cover it again soon to just give people refreshers. Methylmalonic acid is the test that you should be looking for a B12 deficiency. Now, who's susceptible to this? People with GI problems, people that are older. Back in 50 years ago, you used to hear about grandma coming in, 80-year-old grandma coming in for her vitamin B12 shot. Country docs used to do that as a placebo as much as anything else. But there was, like many things, there was some reasoning behind it. Once you get beyond 65, you lose some of your ability to absorb B12. There's a stomach acid component. There's some other components as well. And if you're taking metformin, so especially if you're somebody over age 65 and you're taking metformin, you're at risk for having low B12, not because you're not getting it in your food, but because you're not absorbing it. The way to find that out, again, is to get a methylmalonic acid test. So if you're one of our patients and you have questions about that, we'll go over that with you. Rick asked, took a hard right in my mind and started asking about methylation. Methylation is a slightly different issue. It's associated with the B vitamins. Methylation is the way our body handles that oxidative stressor. Jesus was talking today about the oxidative processes and oxidative stressors. Where does that come from? Oxidation is, it depends on which environment you're in. If you're in a local car shop, they're talking about rust. Rust is combination of iron with oxygen. If you're in a high school chemistry lab, you're talking about, combination of oxygen with something else. So again, burning is yet another way of talking about oxidation. In our body, what we're doing is we're combining, that's what hemoglobin is all about. It's carrying iron, and it's using iron to attract oxygen to create this oxidation process. When we do that, instead of like some lower forms of life, like yeast, which get six energy units out of a six carbon burn, we get 36. We get multiples of that because we do a full-blown oxidation. Other areas in the local shop, especially the high school chemistry lab, we put out oxidation fires by adding hydrogen. In our human body, we don't. We add methyl groups. So what did all that have to do with B12? And why did Rick bring that up? Rick is talking about the fact that the B12 vitamins are where, the B vitamin complex is where humans store methyl groups. So again, we went down two different bunny holes, and I think we confused one bunny hole with the other. If you walked away from that confused, if you're a patient, you have questions about it, please bring it up. Any corrections to help clear up some of that confusion, Jesus?
No, I was thinking about absorption. The word just didn't come to my mind. Like, not because you're eating something, it does that mean that's gonna be processed as it should to. It's part of the pharmacodynamics and pharmacokinetics of drugs and supplements, and it's just goes back to the point of you cannot look just at one single component and make decisions out of that. There are more things in the picture to check out, and methylmalonic acid definitely is something that we're used to test frequently on patients. Tom McCoy, does prolonged fasting raise LDL and triglyceride levels? Seems to make sense if elevated ketone production is causing that adipose tissue to release and a lot of free fatty acids into the bloodstream. If you want to go ahead and take that, because we have seen that with low carb diet, but I'm not sure if we see such thing with fasting. Prolonged fasting usually takes your triglyceride levels to lower levels rather than increasing them.
I would agree with both points. You may see some transient, but you don't see. I'm not familiar with seeing a prolonged impact of both of those from fasting. I just haven't seen that. I'm not saying it doesn't exist, but I live in this world more than most folks, and I've never seen it.
And the other thing that you should know is, even if you increase the amount of fatty acids, some of those fatty acids are used as an energy source. That's why you see an increase in the bloodstream. Some of those get converted into glucose and then gets used, and some of that gets used through other pathways. And we have discussed about going ahead and make a few short content forms on metabolism or some of those. We're going to work on that. We have a long queue, but I'm going to try to squeeze some of those on glucose metabolism, LDL, triglycerides, some other lipoproteins metabolism in a short content form, and try to clear that out.
Thank you, Jesus. So Aldos Marziarta says, what about Praluent? And my answer would be, what about Praluent?
So Praluent is one of those new medications such as Repatha, right, for PCSK9 inhibitors, and I think those have a place on people, especially with FH that have over 300 of LDL, but their benefits are mostly be on the decreasing LDL. I don't know if they have other effects that might be useful in this space.
So a couple of points. Yeah, when you get a question about that, like what about Praluent, you got to guess what was the real underlying question. Does it help decrease LDL? Well, there's absolutely no question. It really decreases LDL. Does it have, as you brought up, does it have the pleiotropic effects, it does appear to have some positive improvement around inflammation, which was a surprise to me. I didn't expect to see that. Another, is it as effective, or is it a replacement for statins? I don't think we can go that far. Another question that may be there is, well, what about Praluent versus Repatha, which you mentioned? Those are the two big contenders in the PCSK9 area. And the bottom line is, we, again, just had a patient yesterday whose insurance company had switched him from one to the other. At this point in time, I don't think we've got enough. I don't think we've got enough evidence, post-market practice evidence, to indicate one is better than the other.
Definitely. So Rebecca, sorry about that. No worries. That's okay. It's because of the last name. No problem about that. Actually, my first because I do have two last names, my father's and my mother's. My first last name is even harder than the second one. Not that hard.
That's a Spanish thing, right?
Yeah, it's
Noyes Vargas, right?
which it has to be Spanish, I think, from Valencia and something like that. I'm not that close to Spanish relatives right now. Thomas Hanside. Yeah,
go ahead.
So going for my third stress test in as many years today. Not sure what the point is. I will fail it just like it has to. I'm not sure what the point is either. If you, and we have talked about that, if you are into a sport, you are an athlete, of course you want to have a stress test and see how your physical condition is. Other than that,
it's not going to predict a heart attack.
Yeah, I mean, if you are not a mathematician and you're failing 3 math tests, what's the point?
Good point. Good analogy. Clean slate. Yeah, I sent my CIMT to Miranda's.
Yeah, that was Dr. Miranda. Yeah.
Oh, okay. So you had expressed an interest a few weeks ago, so I followed up with her. Okay. Well, thank you for sharing that.
I think you invited him to the show.
Oh,
I remember.
Okay.
Yeah. Well, let me coordinate with Dr. Miranda, and get back to you, and we can have a space for you. As you know, we have asked some patients to come here and share their story, and I believe you invited him already.
Very well may have. You know, it's more fun than anything. I mean, it's great having you there. It's far better than
not that I want to replace you, but
and I'm sure you would say the same thing. It's a lot easier than presenting alone, to have someone else, even if they're fumbling and forgetting terms like resveratrol, or rapamycin,
or methylmalonic acid,
or methylmalonic acid. You know, let's not start listing all the terms I've forgotten in one show. We'll be here forever.
Yeah, me too.
But it's wonderful to have a patient, because we get really theoretical up here, and sometimes it wears you out listening to two folks, you know, coming from the same perspective. It's a huge benefit to have a patient who's on the other side of this process, and they say, "Yep, this is what I had." So thank you so much.
And you do a better job than me in simplifying stuff. I'm learning from you on that side. I mean, I've been talking with patients for years, and sometimes it's different how to talk during a consult than in a YouTube show, and sometimes I forget that. I know that the audience is knowledgeable. I'm way above the language.
I have to tell you, that's so funny that you would say that. I appreciate it. Thank you very much. But by far the most common critical feedback I get is, can you dumb that down a little bit? Can you speak that in English? So it's not that's a challenge. It really is. Steve Sapel, excellent program, docs. What about people that follow a good lifestyle, exercise, eat a good diet, have no abnormal blood markers, and still develop arterial plaque and have a coronary event? I'm not seeing you jump in there. So, you know, fools rush in for where angels fear to tread. I'm going to rush in and let you think about it for a second and maybe add some clarification. There's no question that things can happen even if you do everything, quote, right. But I'm going to say a couple of things. I've seen a whole lot of people, and I do this for a living, and I don't know of anybody that's done everything right. I just don't. I mean, we're all humans. We all have errors programmed into our, into our being. I will say, though, Steve, it's really clear that you take 90% of this risk off the table. And there are people that have significantly increased risk. For example, as Jesus mentioned, we met with a young person earlier this week who had two significant problems. Very, very significant FH, not your run-of-the-mill LDL of 200, familial hypercholesterolemia. We're talking more like 300, 325, and early onset of significant prediabetes. So you got people that have some genetic and lifestyle challenges. Genetics you can't change. Age, which is usually the biggest risk factor, you can't change either, but you can change the lifestyle issues. And fortunately, you can take, no matter who you are, you can take the vast majority of that risk off the table. Any other comments?
Genetics is what I was thinking, and I don't think those cases are that happen that often. And I think the most common situation is when people think that all their inflammation markers or all the tests that they have been done are okay, but they're probably not testing the things that you should look for. I'll be very surprised to see somebody with normal LP little a, PLAD2, MPO, CRP, all of that developing plaque and having a coronary event. I'll be really
Yeah,
surprised to see that. It's
you
mostly
just
because
don't.
you're not looking in the right place. If you are already past your stress test and have a basic lipid panel and a fasting glucose that's normal, that's probably when you think that everything is okay.
Yeah,
And we have a lot of people who think that their diet is good enough, that their exercise routine is good enough, and maybe it isn't.
very, very good points. I wish I'd thought of all that.
You give me the time to think about it. So the credit's yours.
Rick Foley, triglycerides seem to be very sensitive to a fasting window. I just did a series of tests to verify. Must be done in a 12 to 14 hour. Yeah, triglycerides do tend to be sensitive to that.
Yeah,
I'm going to have to move quickly. I'm going to, if you don't mind, let's run through these quickly and see if
sure.
there's anything. Chris Linke, I'm currently on extended fast. Is there a maximum length of fast you recommend not to extend? I don't have an immediate answer to that. Do you?
No, we have seen people doing that for up to 28 days, but that doesn't mean not eating anything. Of course, you still have to keep yourself hydrated, and sometimes some tea is acceptable. I think there's something we haven't talked about, and we might want to cover that is refeeding syndrome.
It would be
And
helpful to cover that because that's a big issue.
yeah,
Dennis Williamson's talking about Dave Feldman's Feldman protocol, and his goal was to confuse the insurance companies. There's more truth to that than you would think. Fulvio GA, I'm 58 on Monday. I had my cardiac stress test, and it was interrupted at 97% because of my theoretical max, because the doc saw signs of ischemia. Later, I knew I was anemic. Can it cause ischemia? I see you nodding. You want to go ahead and take that?
I don't know. I haven't thought about anemia causing ischemia.
Well, it does. So for example, I've got you look at people that have in their late 80s, early 90s, some people that have significant heart failure, HFpEF, heart failure, preserved ejection fraction, meaning that they have heart failure on both sides. Then when that's classically one of the things where they really start developing ischemia or loss of perfusion. Ischemia or loss of perfusion, that just means decreased oxygenation to the tissues. And that's the problem. They're already starting with decreased oxygenation because of the heart failure. then these folks often will start getting into just a little bit of anemia, and then that takes them down further to where they're not oxygenating their tissues. So anything that decreases oxygenation, that can be heart failure, that can be um, uh, oxygenation of the heart muscle itself through decreased perfusion. All of these things can cause an issue. As we've mentioned before, though, part of the problem that I have with this concept is that it goes back to that flow study thing where doctors are looking at what are you getting your complete flow to that cardiac muscle, and if you're not, that's really what's going to cause a heart attack. Not so much.
Okay. Yeah, I got it. And this is basically what having hypoxia, because it's basically having low levels of oxygen, can lead you to. And this is, I think, this is what they saw, an issue with the heart rhythm, because that's the way they detect ischemia on a stress test. They see a
Usually.
change of the electrocardiogram, but that doesn't necessarily also mean exactly just blood flow. It might just mean low oxygen levels,
Yep.
and they can track that as well. And that doesn't mean a heart attack is going to happen right now.
For the most part, the biggest concern with relying on a stress test is that 2/3 of people that have a heart attack would have had a normal stress test. So it's false negative is by far the biggest issue. But you do see false positives as well.
Yeah. Or I will be more concerned about dysrhythmias. Dysrhythmias can lead to cardiac arrest.
Yeah.
That can happen as well, and that doesn't mean that's a heart attack.
Very good. So we got some kudos on the show today. I was concerned that the show was going to be a little bit difficult, both in terms of my senior moments and in terms of some of the backwards logic that we covered with these concepts about carb loading and use of a single medication like sirolimus or Rapamycin.
And the ever island of Limas.
That's right. Okay, thank you so much.